Okay, good afternoon, everybody. Um, Welcome to the Michigan House. I'm Joe Voss, the Director of Strategic Partnerships at Create M&A Michigan, and want to welcome you all into the Michigan House. And for our next discussion, I'm going to turn the microphone over to Darel Ross, and who will introduce the panel, and we take it from there. So, welcome. Thanks.
Thank you. Good morning, or good afternoon, Michigan House. I'm Darel Ross from Start Garden. Today we're going to talk about the culture of health, or is there a culture of health? But before we start, how many of you guys know the number one determinant of your health outcomes? Say that again? Zip code. Zip code. So we're going to unpack that a little bit and see whose responsibility that is to fix it. But first, let everybody introduce themselves on the panel.
Hi, my name is Amanda High. I'm from Reinvestment Fund, which is a community development finance institution, a CDFI. So you think of us maybe as a nonprofit bank. We put debt capital into low-income communities to finance things like grocery stores and health centers and arts and cultural assets, those sorts of things.
Hey, Michigan House. My name's Jeremy Moore. I'm from Grand Rapids, Michigan. I work at Spectrum Health, which is a health system that covers most of the west side of Michigan. I'm the Director of Community Health Innovations there, mostly focused on strategy and just community health innovation projects. I also am a Robert Wood Johnson Foundation Culture of Health Leader Fellow. So there are several others in the room. If you can raise your hand if you're also here as part of that program. I know we've got 3 other folks, so I'm glad that we could all be here today. And that's me, a little bit of me.
Okay, and I'm the nerd on the panel. Although I think we're all pretty nerdy. My name is Debra Furr-Holden, and I am a CS Mott Endowed Professor of Public Health and Director of the Division of Public Health at the Michigan State University. Go green!
Go white.
Go green. And the primary work of our Division of Public Health, we were formed in partnership with the 3 leading hospitals in Flint, McLaren, Genesis, and Hurley Hospital, as well as the community and the Mott Foundation, to develop community-engaged solutions to address, mostly from a public health perspective and a structural perspective, the problems that are facing Flint. So we'll talk a little bit more about that as we get into it.
Cool. And once again, I'm Darel Ross from Start Garden. Start Garden is located in Grand Rapids, Michigan. And what we do is entrepreneurial development and ecosystem work. Because ultimately, in our opinion, the best way to change outcomes in zip codes is to increase wealth in those zip codes. This panel came about a lot from this Invest Health. So Invest Health was this collaboration of 50 mid-sized cities across the country to come together and really talk about health disparities. But more than that, how do you get and affect some of these health disparities from a non-clinical standpoint? So you're probably wondering, why do we have a bank here? Why is a university here and a researcher here? Because really when it comes down to it, we all have a role in it. But first I want to start off from that Invest Health standpoint of discussing your individual roles and what your organization or you personally brought to that work and why it's important to have that perspective.
So Invest Health was an initiative funded by the Robert Wood Johnson Foundation, and we're extremely grateful for that support. They channeled funding through us at Reinvestment Fund to design a program that would bring together 50 small to mid-sized cities in leadership teams of 5. So these teams were cross-sector teams representing anchor institutions, community development organizations, the public health sector. And for 18 months, we gathered virtually, we gathered sometimes together, and there was a coaching element to the city teams as well to try to encourage them to develop a pipeline of built environment interventions that would affect health outcomes in a positive way. So looking at the social determinants of health and how those determinants could be ameliorated or improved in some way through, again, interventions mostly in the real estate environment. And so that's why a CDFI like Reinvestment Fund was considered by the foundation as they were casting around the country for who to run this thing. That's kind of why we were chosen, because we work on those financings and have the same intention around improving health outcomes. So that's sort of a little bit of the Invest Health story, and Jeremy and Debra are both members of teams from Michigan. There are 2 other Michigan cities that were included. Actually, Michigan was the one of 2 states that had 4 winning teams, so right up there with the Liberals in California. So very well done, and we've really enjoyed the journey with the Michigan teams as well as the others.
So this is a story that kind of gives some context to some of the work that we do. So just a few months ago, I was told by a friend of mine who's also working for a nonprofit around housing remediation. So, housing that literally kills you, right? Where you get lead exposures or asthma. His nonprofit actually works on remediating the environment so that the housing is more healthy. And he told me a story about a woman who lived in an area that was historically segregated and divested from in the city, like often we see in many urban centers. It was a woman whose child ended up being exposed to lead, and she lived in a rental, and so she called the city to ask for an inspection, but at the same time, she was given an eviction notice. And so when it came time for her to go fight her eviction, she called the city to see where the inspection was, but they had canceled the inspection because she had gotten the eviction notice. And so she ended up out on her own without housing with a 2-year-old child. And also she was due that week to have another baby. And when you look at this story, you look at the story of housing that was either too expensive or that she couldn't afford, a policy within the city that ensured that she wasn't going to be supported in the situation that she was in. You look at housing infrastructure that is poisoning her child. None of these things have to do with walking into a doctor's office or not. Not one aspect of this has to do with the access or quality to care. And I'm not diminishing quality of care or access to care. I think those are important things. But what we know is that about 85% of your health has nothing to do with access to care. It has to do with who you are, where you live, and then some genetic pieces as well. And so when we think about that, this is why I'm bringing this back to the Invest Health work. This is why this is so important, that health is more than just improving access or quality to health systems. So what we did in Grand Rapids was specifically focused on a specific targeted area where we knew that we saw about 1/3 of the people in Grand Rapids live and about half of the poverty. You saw racialized outcomes within this sector, not only health outcomes, but every single measure of well-being. And we began to focus on who are the people that are doing the good work in this area. And we went through this whole process of community engagement. We went through a process of looking at the data, and ultimately landed on 5 different areas that we really felt like we as a health system wanted to support and scale up. And that was around healthy and affordable housing. It was around economic security. It was around food security, and also child and maternal health. And kind of the difference in how we wanted to collaborate around this was oftentimes there's a history in Grand Rapids, maybe in your own town, where you kind of get this large backbone organization that wants to kind of manage the process of how this works. And we sometimes call this managerialism, where endless committees and things that ultimately result in nothing happening. But we know that there's really good work happening on the ground. And so our rule number 1 was, who's doing good work? How can we support you to scale up this work so that it's meeting the needs of more and more people? And we're going to figure out how to tell this data story at the back end. But the reality is that you can't tell me that someone isn't healthier if they have a good house or a better paying job. That's our story that we need to figure out how it relates to the business of healthcare. But we know that that's what makes people healthier. And so the issue in that is, figuring out how to tell that story from our end. And that's how it's changed our work, is that community-based organizations and people and the resiliency of communities, they've been doing this work for a long time without the support of health systems. It's actually to our benefit to figure out how we can better align with the work that's happening in the community. And so I think a lot of what Invest Health is for us is figuring out how do we more sensitively connect and support a lot of the work that's happening within some of the communities itself. And there's more to elaborate on that, but that's just kind of the salvo of what we're working on.
So I just had like an aha moment. Like one sentence earlier, I was like, hand me the baton, hand me the baton. Because honestly, what you said, I think is spot on. If people don't have things like housing that's conducive for health. If people don't have what they need to feed themselves and their families and all of that, how can they possibly be healthy? So in public health, to me, it really is the science of those solutions from a health perspective, right? And so you asked this question at the beginning and you said, what is the number one determinant of where you live? And somebody said zip code. So as a public health person, I'm like, rah, that lives for people, but the science behind that and then the solutions that we build are much more complex than that. So what we've learned is if you just change somebody's zip code, you just move them into a new neighborhood without having all of those other particles in place. There's now good science and evidence behind who you move and how you move them and what other kinds of things need to be in place. That's why public health is so important here. The thing that I find brilliant about Robert Wood Johnson Invest Health Initiative is it gave people like me, the public health people who really have the science and the evidence around how to do this from a systems perspective, access to people like Amanda who say, but this is what you need on the investment side. How are you working with your local, CDFIs and your local investment institutions? Because if you want to get people into opportunity, that costs money. That has to be funded, right? And then linking that to the healthcare system. So I think the sort of model and the marrying of all these sectors is really brilliant because we can bring the science of those public health solutions with real evidence behind them, and not just on what we should be doing, but also the science of de-implementation. I think we've oftentimes implemented things that were well-meaning, that on their surface made sense, but when we actually did the research and the evaluation behind them, we found that they cost a lot of money but didn't yield the biggest difference. So I think that marriage of these multiple sectors, people delivering the care, people funding it, and people trying to understand from that, public health research evaluation perspective is where we should be headed.
So let's go down that path. So a lot of times we talk systems, whether that's healthcare systems, ecosystems, and to me, systems mean there's a lot of moving parts, right? So there's never going to be a silver bullet solution, a lot of silver buckshots, as I like to say. So the other thing about a system is systems are perfectly designed to get you perfectly what you're getting, right? So can we kind of unpack that from your individual sectors, kind of walk through that history? How did your sector historically get us here? And then what are some of those innovations that we've learned? What are you applying to kind of change some of these new outcomes? And I know that's a loaded question that I won't be able to repeat again, so you guys can jump in, like whoever wants to jump in. But yeah, the history of your sector, like how did it contribute to today's reality, right? And what's being done different? Where have you seen innovation within your individual sector? Then we can kind of bring it back up a little.
So I would like to say one thing to that. When we look in Flint right now, and you'll hear these stats that Flint is the poorest city in America. I just saw that we were ranked the poorest city in America based on the annual 2017 census. They do these little mini updates in between the decennial survey, and it's so misleading, right? You'll hear Flint has, the population has declined by 50% in the last 20 years. Those are actual real stats. But the city of Flint is a little teeny box in a much bigger landscape. That's the Flint area in Genesee County. And quite the contrary to the air quote Flint story, Genesee County has actually experienced population growth over the last, 20 to 50 years, by and large, while Flint has experienced a decline. But we're talking about the little square in the center of the picture. But there are some key things that happened along the way that account for that. Flint used to be the center of the city. General Motors came in, everything was sort of in the center. And then, the big migration from the South of both whites and blacks, it was just prejudice. People wanted to live by people who they wanted to live with and not by others. And so a lot of the whites moved to the suburbs because they could afford it and the system supported that, right? So then we've got this little box in the middle called Flint, but that was sort of the economic center of the city, and it supported the whole region. Well, as white flight happened and people moved out, they said, you know what? We don't like this consolidated model. We're gonna disaggregate this stuff, and Flint can pay its own way and the suburbs can pay their own way. Well, at that point now Flint's on the downside, So like you say, these systems are designed to perfectly get what they got. Like this was not an accident. So I don't pretend, I always tell people, policies are not built on data. Like I believe that we need to have the data because we need it at the ready so that we understand. Policies are built on politics. What happened to Flint was an intentional divestment, and that similar reinvestment could actually unring that bell. There are real policies that we could put in place that would unring that bell. We could have a regional approach to taxation and resource allocation. But we choose not to do that because we have a system in place that actually supports the thing underneath of it that we really don't talk about, which is racism and structural racism. And the fact that whether people are the conscious beneficiary or not, there are lots of folks who have a lot to lose if the system actually had equity built into it.
Yeah, I agree. I think when you look at healthcare, yeah, we can give that a hand. I think oftentimes there's a tension. It's really difficult to talk about localized work when there's a larger system at play that is exactly designed with built-in like racialized outcomes. Anytime you commodify something like healthcare, it changes the lens by which you look at it. And so when you look at things like healthcare, so research definitely shows that the more money you have, the better your health is. And if we look at racialized aspects of wealth in this country, where what is like the most recent stat is like the average white family has $116,000 worth of wealth, and then the average black and brown family has, I think, like 8,000 or 9,000 or something like that. If you commodify healthcare, all you're doing is calling the lower end of that, which is racialized, a failed market. I mean, that's really what we end up in. And so as long as we're commodifying healthcare, you're going to end up with a total inability at any kind of local level, given that larger policy, to be unable to deliver healthcare. And so sometimes, when you talk about the challenge in that, the challenge is being able to change that higher level policy around commodification. I think the ACA was actually marching towards that. When you start looking at going from a volume to a quality-based reimbursement system, the thing that happened within health systems was all of a sudden it became a story of if I have a heart attack and I go to the emergency department and the doctor's like, Jeremy, you need to stop smoking and you need to stop, whatever, or you have a genetic condition that you need to pay attention to, whatever, and I say, whatever, doc, I don't want to do that, and I go back home, and then I have another heart attack and I come back in. Every time, without a quality-based reimbursement system, the hospital gets paid every single time for that. If you change that to a quality-based reimbursement system where the third or fourth time I come in and I'm not doing what I'm supposed to be doing, but the hospital still has to pay for that, or still has to serve me, but they're not getting paid for it, it all of a sudden elevates prevention on the agenda for the system itself, right? And so that made everyone nervous. They were like, how are we going to make Jeremy stop smoking? It's like, that's a really good innovative question for health systems to answer, right? Like, that means that we probably have to think outside of our physician walls. It means we have to get out into the community and figure out, like, why do I smoke, right? Or, why do I eat the way, why do we do these things? What is health? Is that the most important thing? And so when we change those larger policies, I think that's where the discussion really needs to sit, because I feel like a lot of times at the local level, we're trying to work with a Band-Aid that doesn't, that'll never fully fit, and it'll never really get us to where we want. I don't want to sound like dystopian with that, but it feels like the priority.
That's good.
So, the question I heard was, how did our industry, my industry, the community development finance work, contribute to where we are today in terms of the difficulties? And, I think about what we measure. So we're a mission-based lender, we're a 501c3, and when borrowers come to us looking for financing to low-income housing, a grocery store, there are impacts that we measure and we ask them to report on. One of those impacts is not, how have you improved a social determinant of health? How have you named it? And how are you measuring that you have done that? It's a given that a better house, a more reliable source of nutritious food would improve someone's health. But if we're not asking that question, and if we're not putting financing instruments on the street that are aimed specifically at those outcomes, I'm not so sure that we're getting the greatest impact we could. There is some de facto sort of improvement that happens, and we can all say, well, we know that. But if we said at the beginning, how is this grocery store meant to improve someone's nutritional profile? Well, maybe that grocery store would be laid out differently. Maybe different people would be standing in the vegetable section talking to folks about why they're over in the snack aisle, right? So we haven't done a great job of naming what it is what we're trying to do at the community level around health itself in particular.
Right, and I'm assuming that's a reinvestment fund answer, right? Because I think to the bigger sector of banking, if you historically look at redlining, how loans are originated, who the money went to and so forth, if we're saying wealth then equals health, then historically banking has not done a terrific job, I mean, which also led to CDFIs and some of the great work of reinvestment funds. So maybe you want to talk about how you are different from that traditional lender and how your ROI isn't necessarily just 2% or 4% on this portfolio.
So we're looking to be repaid, right? We put money on the street and it comes back and then we put it out again. So there is a fundamental set of underwriting questions, just like traditional capital institutions would ask. We ask those questions so that our core balance sheet functions and is strong, but we also ask questions about other kinds of impact and mission fits that are particular to something we're trying to accomplish in a neighborhood. And the issue is, are we asking the right questions, and how do we measure that? I mean, a challenge for us at the moment is in this interest rate environment, which is very compressed. A borrower might come to us for financing, might also go to Wells Fargo. Well, Wells Fargo isn't asking them those mission questions. Wells Fargo isn't saying, a year to 10 from now, we want to know who's living in these housing units, what sort of condition they're in, how they've been maintained, and you got to tell us that in order for us to cut this deal with you. So they can go down the street as a borrower and not have the hassle of the mission piece. And one of our challenges, since our money these days isn't that much cheaper, is making that mission fit compelling for the borrower. And it's a real challenge. And there are borrowers who get it, and we're happy to continue to finance them, and then ones who just simply aren't in it for the mission and impact piece. And how they become incentivized to care about that is a struggle for our industry.
Okay, I'm gonna get you guys, Jeremy and Deb, in some trouble maybe, but since I'm moderating, I can do that. We talk about this culture of health, and me and Jeremy have had this conversation ad nauseum of the culture of community. So when it comes to health disparities and health outcomes, which is more important and where is that balance? So you spoke to your culture, right? And so you know you shouldn't smoke, but you smoke. My culture, I know I have high blood pressure, and I promise you I ate bacon this morning. Conversely, the culture of healthcare is everything is clinical, go to your doctor more, it's assumed to be an access issue. When we look at these social determinants and we look at where the sweet spot of impact is it the culture of the community that we should work on, i.e., if you know better, you do better, or is it the culture of the healthcare system that we should focus on, and where is that balance as you guys see it from your perspective?
I think that's a good question, but the answer is probably even a little bit more complex than the question. So the thing that I really like about public health and the social determinants of health framework is we always put it on the individual. We've always said,
personal responsibility.
Yeah,
Personal responsibility.
One of my favorite examples, there was a study that came out within the last decade, and this woman identified that I think African American children hear something like 20 million fewer words by the time, spoken to them, by the time they enter into like first grade. So she developed this intervention, and the intervention was to train mothers and caregivers on how to have more conversations with their children. And I just thought that was so uninformed and so off base, because what she found when she actually did that work, can you imagine what she found? They were working, they have 8,000 more demands on them. It wasn't like,
Right.
it implied that the problem
Yeah.
was the mother, as if poor African American or Hispanic or minority women don't have the same goals, aspirations, and dreams for their children as white mothers, right? But here's this research or something. This is a part of the gap in public health, right? Even with this social determinants of health lens, in public health, our training right now, historically has been focused on health. And then we look for health solutions. And we look for, kind of population level solutions. So I'll tell you, one of the biggest victories in public health is fluoridated drinking water, right? Because we could address dental caries and all these other things with like this one, magic bullet, right? Mm-hmm. But a lot of the issues and things that we're dealing with now are much more complex with that. But the way that we're trained, the people that we work with, the people who are in our field, like this is like, may sound like real ho-hum passe to you all, but this is not how we're classically trained now in public health. So there's this rah-rah social determinants of public health, and if we can even get people to think about neighborhoods, okay, great, but then they do things like publish and say, so we need to fix the houses and the this and the, and they pose these pie-in-the-sky solutions, but have never dealt with the CDFI, have no real clue of what it takes to do that, but their data informed them or told them something, and so they throw that out. And we do the same thing. So you're saying like, how do we push the ball back to the hospitals and say, if Jeremy's coming in 4 or 5 times, you don't just get to tell him and him keep coming back to the revolving door and you get paid. You actually have to, sort of find some solutions so that Jeremy has what he needs to make those changes. Right. Public health puts pie in the sky solutions out sometimes. It's why I truly think the partnership is better. So for my discipline, we actually now need to do what we did when we learned how important health education and all of those things were. We need to expand our own conversation and get people even further upstream in their understanding of how things work, so that the work that we do and the research that we do actually has some real connection to how things work in reality.
Yeah, this is a really important question, I think, because the narrative in this is so often about the kind of pull yourself up by your bootstraps narrative.
Or even if you know better, you do better. I mean, how many times have we talked about food access piece, or food, and we just teach black people
how to
about
eat
those
better.
salty foods, their blood pressure will be better, as if.
Yeah, so the story, actually, this is really, a couple weeks ago, I sat down with a young woman who she's a colleague of mine, but she recently got a job at Spectrum Health through the West Michigan Center for Arts and Technology, which I think we have some folks here from there right now. Yeah, they're here. But it was powerful in that, she talked about how she had been working at a $10 an hour manufacturing job, got the opportunity to end up at WMCAT, and they do like this adult workforce accreditation to provide an opportunity to get into a coding job, in this case at Spectrum Health. And to do that, for the first like 7 or 8 months of this, she's got 2 children too, so she had to work basically 18-hour days, Monday through Friday, where she's working her job, she has to do the accreditation, and then she's got kids too, and so on the weekend she's hanging out with her kids, and they really had to figure out like, how do we make sure that she succeeds, and not because she's not working hard. I don't think I could have done what she did. As a matter of fact, when she got to 7 months, she actually like started to get ill. She had to quit her job, take all of her savings, and basically invest in herself for like the last 5 months of this class in the hopes that she's going to get a job at the end of this. She does have a job. She actually has a nice house now with a pool, which is amazing. And I'm like,
it's all about the pool.
Yeah, I know. But the problem with this isn't that she didn't work hard. Like, she was working probably harder than I am, honestly. It's that we have a system that absolutely does not incentivize or reward her for the work. And this is what I think we have to get into, and when we think about health, is why do we allow our systems to do this? I think sometimes we get so caught up in process, and I get that. I'm not an ideologist. Like, I'm very much a materialist in my philosophy, which sometimes gets me in trouble. But the problem is that we don't have a vision for what our community should look like. Like, we don't have any kind of shared vision and we so often get in like, well,
Or a
you know,
shared definition of what a healthy community is. Right?
Like, you know, this is unrealistic. Like, how would, you know, people just have to work hard and this is kind of how it is. It's like, why? Like, I mean, I get that people have to work hard, but like, why do some people get rewarded for their hard work and some people don't? And are we committed to solving that issue? And I truly believe that if we all engaged on this problem, we could figure it out. But I think the fundamental issue for us is just the lack of will in wanting to do that and understanding and agreeing on how we got here in the first place. And I think the kind of the American myth of, you know, self-made man kind of thing gets in the way of that.
Yeah, I always say in America, we're unique in that we have this penchant and this ability to ignore material fact in history. And we always deal with problems without doing that. But because I want to get to the audience, tell me what excites you. I mean, so we've kind of framed the problem, talked about history. Sounds like kind of doom and gloom, but I know you guys are all doing exciting work too. So what's going on that's innovative? What are you excited about? And what changes are you seeing that just excites you that, you know, we are going to get this right and that we're closing this gap? Don't all jump at once with the excitement, you know what I mean?
Oh, no, go ahead. Go ahead.
Well, I will just tell you, I call myself a researcher activist, but I wasn't trained in activism, right? And so I sort of, you know, the sort of joke with some of my colleagues, and I started Johns Hopkins, and I went to Morgan State University, which is a historically black college university, and I'll never forget them telling me I had been whitewashed, right? And what I actually realized, and I get what was underneath of that, which is like some of the ways that you see things and some of the ways you think about things are coming out of a tradition and are coming out of research that was to further an agenda, not really to uncover truth and build solutions that were equitable, right? Mm-hmm. So to that end, yes, but we all run the risk of that. But what I actually got was I was well trained. I could take those methods, I could take what I had learned. It wasn't until I really got in the world that I realized the real power of the skills and the tools that I had. So what I had to do was sort of build myself up and get these other conversations that were not common conversations. They might be common in a room like this, but they're not common out in the world. And I'm sure you all know that. You experience it in your family, in your communities, with even some of your friends and other things. People say stuff and you're like, really? You really believe that? And they hold it as a truth, right? So I will tell you sort of the hope for me is, and I'll spare you, but in the background specifically for public health, there's not been a lot of incentive for people to work this way. Mm-hmm. There's not really been space for a researcher activist because that yields fewer publications. It doesn't necessarily bring in external grant funding. It doesn't map on to all those markers.
Doesn't fit inside the box.
You know what I mean?
Right.
And so then, you know, you have things like the Robert Wood Johnson Invest Health Fund, and they require as a part of the team an anchor academic institution, an anchor healthcare institution. So it's interesting to me that these, you know, because money talks, that it's this coming together of people from different sectors exercising their will and power and influence. I don't care if it's money, because Michigan State University has a lot of power. They have a lot of say in Michigan. They have a lot of money in Michigan. And so I'm sort of looking at how my field—
They're almost like U of M.
Get out of here.
Get out of here.
So 2 points of excitement, both of which have to do with Invest Health. It's worth knowing that the grants that were awarded to these cities were small. And with the funding that was awarded, the city teams had to travel 4 times around the country. So we're talking about $60,000. So of the 50 teams that were selected, we had 197 applicant cities for 60 grand. And I think that's thrilling. When we first looked into taking this on with the foundation, we were frankly concerned that we were going to have to hit the road and really beat the bushes to get cities excited about this opportunity, because there just wasn't a whole lot of money connected to it. And the fact that people were excited, I think, is a testimony to the degree to which this conversation is, in fact, permeating our society. Now, not everywhere, but in a whole lot more places than you would think. There are people who are understanding that the cost of people being unwell in chronic or episodic ways is borne by all of us and is insupportable. And as grave a moment in time as it is, there is really coming to be an understanding that that's the case. And so these cross-sector conversations, which are hard, conversations about changing embedded systems, which are very, very hard, are being taken on by people because it's imperative. And I think the understanding of the imperative is very exciting.
Right. What excites you, Jay Moore?
Yeah. So yeah, actually echoing a lot of what you both said, and I think there's an increasing recognition of the kind of interconnectedness of these sectors, and that one sector isn't going to solve it. I mean, we're doing a lot of interesting stuff. Like we were like through Invest Health, like we got like new housing, like new affordable housing, attracted a low-income housing tax credit. We have a Pay for Success project that's scaling up child maternal health around racialized infant mortality outcomes. But the thing that I'm most excited about is collectively, this is 30 organizations, public sector, private sector, nonprofit groups that all agreed that the one thing that they want to work together on was around economic security. And so that's not, we teach you, you do better. That's literally saying, in this area, we know that people have less money. And so how can we, and we serve the folks coming through our door have less money. And so rather than scaling up our services, can we just get them more money?
Right.
Because we believe over time, there's a hypothesis there that over time, people want the best for themselves if they have the resources and the ability to make the decisions that they need to make, like I do. And so rather than being paternalistic about it, what can we do to deploy access to capital, specifically for the neighborhoods of focus for business startup? How can we deploy actually living wage jobs, like access to living wage jobs? How can we deploy things like available childcare and transportation? And I got to give credit, Dr. Ken Fawcett, who is my boss here, he's given me a lot of leeway to be able to work on a lot of this stuff. And I think that's really important, and that's not something that you often see in health systems because it's a bit of a reach. I mean, we're trying to figure out how this connects to the business of a health system, and it doesn't always, because our health systems are paid in a way that doesn't allow for that incentive. But I think if we're allowed to explore that a little bit, I think we'll figure it out. And the health system that figures it out, how to do it really well, is going to be the health system that survives a lot of the health system disruption that's going to happen over the next couple decades.
Right. Yeah, I think that, not that I'm on the panel, but I'm going to be on the panel. Yeah, so that's what excites me too. I think, I know I want your name tag. That's a whole different conversation. Where was I at? What excites me is, and I think just in the line of equity work, but definitely within the Invest Health and the healthcare sector, is I think we're getting to a conversation and to a point where we're actually talking resources over services. And historically, you go to Black and brown people and in their communities, and it's if you knew better, you do better, and it's all services and training. I think for the first time, even in healthcare, it's about now getting resources. We were able to partner with Spectrum and around affordable housing, around entrepreneurial development, understanding that resources kind of eliminate the need for services, which is totally a different way of thinking, especially where I'm from in Grand Rapids, Michigan, where I think we're like #2 in philanthropy across the country, second only to Utah or something like that. Yeah, Salt Lake City. So,
and I'm gonna push back. I don't think resources eliminate the need. I think
Reduces.
They greatly mitigate.
There you go.
And balance the need.
There you go.
Yeah.
So to have that as a real conversation, is light years, I think, from where we started. But I want to get to the audience. So are there any questions out here for the panel that you have or may have? Ma'am. Hold on 1 second.
Hi, my name is Alma, and I'm with Enterprise Community Partners. So I come to the community development from the housing side, but we're increasingly trying to, silo bus between housing and healthcare, and really, thank you, Spectrum, for the work that I hear that you're doing in Michigan. A couple of questions. You had indicated that that there are, that there is not really, plans around looking at community development, and then from a policy perspective, was wondering if there's any improvement in the community health needs assessment, which hospitals are required to do? That's the first question. Then I'm going to put another question in. You're doing a lot with capital and using it creatively, and there are community benefits, requirements, which my understanding that may not necessarily be a lot of money, but then it's actually accessing the endowment that most hospitals have. How would you, me as a houser helping community development corporations, what advice do you have, for me and for the CDCs to actually speak to hospital and hospital systems in a different way?
That's a great question. So we actually are a little bit unique in that when Spectrum Health was formed, it was formed by the merging of several hospitals. It created a charter, so we have a requirement of actual cash out into the community. So a $6 million cash out, about $1.5 million of it is actually money that goes out in the community, and the rest is internal programming that fills gaps. It's funny, I just did a panel for NFF on this exact question about how to engage hospital systems. And my first caveat in this is that I actually think it's more of a benefit to hospital systems to want to talk to you more than it should be you to try to have to figure out who to talk to in the health system. And so my first thing is you can take this tape and bring it to a hospital system and say, other hospital systems are saying that you should listen to me because you're serving the people who are walking through hospital doors. And so you've been doing this work whether or not hospital systems have been working with you or not. Like that's the mission of your organization. A really good connected system of health considers the fact that housing plays a huge role in someone's health or not. And so my first thing is that I think it should be the hospital's responsibility to figure out how to connect with you, but I know that that's not happening everywhere. I think the biggest thing is trying to find allies within larger health systems that understand the connection between this. Oftentimes what you get is, I don't understand how housing, like the data story between getting someone a house and how this like saves money for a health system or something along those lines. I think it's dangerous to go down and pursue that as a start with the health system. Like our mission, for instance, at Spectrum Health is making the communities that we serve healthier. And so you can't tell me that getting someone a house and making sure that they're well housed doesn't make them healthier.
Well, and I'll jump in. I used to be an affordable housing developer. So the CDC and community development organization started around community, and then they added this development piece. So it was always this balance of what's best for the community and then how do we fit housing into it, understanding that. Fast forward to the competitive world of LIHTCs and so forth, what happened is there's a lot more commas and dollars on the housing side. So I think one of the things housing organizations have to do, especially affordable housing organizations, is not do housing in isolation. You find when I was with the organization, we used to always argue that we were building these beautiful islands around a sea of despair, because you can get a person a brand new house, floor to ceiling glass, LEED certified, but if you didn't work on the community side, the social fabric, where you're really doing revitalization, I would point you to Link Community Revitalization out of Grand Rapids, who has a real robust model of economic development married with housing, married with advocacy. So I think it's on both sides. I think housing developers have to start singing this song too, of how it takes more than housing to do revitalization. And I think, to Jeremy's point, I think there's healthcare systems, funders, and so forth, who at least now are more ready than ever to kind of hear that. But I think the housing, affordable housing in isolation is part of what has to change in that. And I forgot the second part of your question, I'm sorry. Okay. Cool.
Yeah, and just one more thing I want to tack onto that. Something that's really helpful too is, like when through Invest Health, when LinkUp got the LIHTC credit, we really didn't provide any funding around, I mean, maybe a little bit around some of the research around that. But where we were used was around advocacy. So talking to MISHDA and saying, hey, MISHDA, which is the unit of government in the state that actually issues the LIHTC credits, we're investing this much in this community, and so that helped raise the number on their application. So not just money out, but also we're a big institution that has a big footprint that can advocate. But oftentimes I don't think hospital systems think in that way around like how we can advocate for our patients outside of like making sure that they have Medicaid reimbursement, or things like that. So their lobbying power is really strong too, and that can often be accomplished through like health association. So we have like the Michigan Health Association and things like that.
I want to add one thing. It is something real practical that we did. Again, I'm putting my public health kind of researcher practitioner hat back on. We specifically looked at, in a city like Flint, Flint had many problems, structural, public health, economic, and all of that, just challenges and things that it was dealing with that predated the water crisis. And Flint was holding on in the face of that. But it was just barely, it was just holding on. And so the water crisis was, for better or worse, something that brought more attention to us, but it was by no means the worst thing that has happened to Flint in the last decade, right? And so we started to look, because what happened is a lot of people started to parachute in. There was literally bidding wars for Flint baby teeth. Why? Because lead resides in bone and it resides in teeth. It's like the rings on a tree. So we got researchers from Yale, from North Carolina A&T, from all over the country who want Flint baby teeth so that they can study their lead exposure and then follow these kids over time and look at their outcomes. Is that really going to benefit Flint children? No. But when they get into bidding wars and somebody says, we'll give you $50 a tooth and you're a poor mother, where else are you going to get $50 that easy, right? So we had all these sort of weird things that were happening, and we realized our population was both being exploited and they were being fatigued, because there were real things that were happening that we wanted to understand. How do we impact that? And we actually have now sort of married with the community health needs assessment. That was not a trivial thing that you brought up. I said we are required to do this every 3 years. Something that already exists is our 3 hospitals already come together and do that collaboratively. And we said, okay, us now as this new public health entity in town, a new stake in the ground. We have a center that I run called the Flint Center for Health Equity Solutions. How can we use something that's mandated, that's required, and integrate all of these other things that we know that are important into this, mandatory work that the hospitals already have to do? So we have greatly expanded and have this multi-partnered approach now to what our community health needs assessment looks like. It includes those social determinants of health. We actually created a novel metric called the Community Healthfulness Index that is something that we plan to track over time to see how that changes. That's just got accepted for publication, so you'll see that coming to a journal near you. The reason I say it's important is because we got to disseminate and have others know, as we learn these best practices, how do you then replicate something like that in your own community? The piece that we're now starting to fill in is, okay, so the hospitals got the individual delivery of care. We're looking at the sort of systems of care and these other structural and bigger factors beyond just services. Well, now we've identified some of the needs. Who's actually going to fill them? It's not a one, as we've already said, a one sector approach. We need the CDCs, we need the hospitals, we need the anchor institutions, we need the faith community. There are many pieces that are needed, but we have used the China specifically as a place to anchor this ongoing evaluation and assessment as we start to create those solutions.
Any other questions?
What kind of baseline data are you guys using to, figure out their social determinants?
So I'll give you an example. Reinvestment Fund is about to finance a multifamily housing rehab in Greensboro. And Greensboro was one of the Invest Health teams. And they created a case for this financing application that began with pediatric asthma visits to the emergency room. And they measured from that census tract what those visits looked like and what it was costing the hospital. And they used that data point and that argument to go to the community foundation and come up with some equity that will be paired with our financing, such that then we've blended down the interest rate to where it's something that can really be serviced. But they led with a health statistic, and it created the case such that they were able to attract other pieces of financing. And that was what we had hoped from the very beginning, was that the Invest Health teams would figure out how to construct a narrative around a health impact that spoke to capital providers.
Yeah, data is a really difficult thing because our data just isn't inherently connected. It's often politicized. It's often owned, by different kind of pieces of the puzzle, right? I think where we do a really good job on data is more like very specific projects. So I mentioned this social impact bond, pay for success project that we have around child maternal health. There's a very rigorous data evaluation structure that's connected to that. That actually we work with Michigan State University on this. It involves administrative data at the state level, but it's very much honestly like a one-off system, and so we don't have like larger data enterprises that help connect how does school absence connect to emergency department usage or things like that, and that's kind of the holy grail of what we'd love to look at. I mean, we're talking to larger kind of impact evaluation groups like the Sorensen Center in Utah to talk about how can we begin to construct something that gives us something that's real time, sensitive enough, so we know without having to have like a 10-year process from idea to finish of whether something's working or not. But I'll be honest, we're just not there like in connecting all these different systems at the broader level in the way that we want to be right now.
I can tell you one thing that we just started in Flint. We have two things. One is we have a system called Open Data Flint, because there's a lot of historical data that exists that is important for understanding sort of how we got here and what the trajectory and the trends look like. This was one of the things that came with the water crisis. People said, oh, well, lead was already sort of, on the decline, and then there were a couple of blips. And if you look at the trends, then what happened during the water crisis was just another blip. So that historical data was important because that was the narrative that people were going with, even though the data really didn't support that. So we created something. So we have this, and it's literally, that's the website, opendataflint.org. So we have a data repository now where we put a lot of historical data, and we're not gatekeepers, it's not mandatory, but we've gotten buy-in from the C.S. Mott Foundation and others that actually do grant making in the city to say, could you please require your folks, put the protections in place. They can strip the identifiers off, but they got paid to do great work for Flint and Flint residents, and the benefit of that work should be maximized. And how it gets maximized is that data then becomes a resource for the community and for the city as we begin to figure out what's next and what our people need, and also try to evaluate the impact of all of this work. Yes, from both the project perspective, but also what is the collective impact on sort of all of these projects that are happening at the same time. So that's an important thing. I think there are real systems. I actually did this work in Baltimore and was one of the people instrumental in getting the system in Baltimore, which is called Open Data Baltimore, which is now like a sort of national model for how to do it. And we're building that out in Little Flint. The other thing that we have is something called the Flint Area Assessment Stakeholders, because there are all of these people who have skin in the game. And again, I said we started by anchoring it around the Community Health Needs Assessment. There are all of these people that have skin in the game because they need the data, whether it be a grassroots community organization who needs to make a case for something, so they need data to be able to frame the narrative, whether it be a group that's coming in and trying to get some investment dollars and they need some data to be able to substantiate it. There are all of these folks. What we found is we had a lot of people going out, knocking on doors, collecting data, et cetera. I'm a researcher. My money has limitations on it. I can only do research with that money. I looked at the Community Foundation and said, what's gonna happen when we go knock on somebody's door and the lights are off? You don't have those restrictions on your money. Whatever data you need, when we knock on the door, we'll get that data for you. But if we find somebody that needs their light bill paid, then you're gonna pay the light bill. So let's be efficient with the resources that we have and use them in a way that makes the most sense for people. So you can formally bring people together and you can formally start to put data together in ways that are actually useful for everybody.
Cool. I think we got time for one more question.
Hi guys, my name is Phil Coleman. I'm from Ann Arbor Spark in Michigan. So it's an economic development organization. We work with many different startups. So you guys mentioned lack of resources playing a part in not being able to create that quote unquote healthy community. And I guess my question is, when I think about technology and the increase of people being able to have access to the internet and things of that nature, it's kind of helped level the playing field in some ways as far as access to information. And we're seeing a boom in the healthcare industry with different innovations surrounding technology in healthcare. One company comes to mind is Spellbound. They create distraction tools using augmented reality for patients who are going through chemotherapy, or they're using it for something on a small scale as far as a child who would like to get a shot but is afraid of needles. Something like that. How do you guys feel technology will play a part or a role in creating that healthy community as far as what you talked about earlier?
I'm not a tech guy, but I play one on TV. I think it's clear that there's a lot of room for disruption in healthcare right now. Like, I mean, just the fact that like Amazon enters the market, and Warren Buffett gets behind it. They're probably not doing that because they don't think that there's, not disruption to be had there, right? Like, and the reality is if I look at like my own healthcare experience, I have a CVS that's, a block from my house. If I could get most of my healthcare taken care of, by walking down the street within like 5 minutes, I'm doing that. And so I think there's a tech aspect to that. There's a retail aspect to that is going to revolutionize at least service delivery in healthcare.
And that's what I was going to say. So I think on the tech side, especially around entrepreneurship, venture capital, and startups, it's mostly of the quality of care. I think what people aren't paying attention to is how tech is going to potentially change the delivery of healthcare. And we have that conversation. Yeah, Amazon buying healthcare systems and so forth. That's a tech company jumping into healthcare, right? But we often talk from the venture capital side or the investment side about the Fitbit or how you're tracking it. So I just think you have to put those into those two different categories because one is going to be transformational. One is just the application of tech and how is that going to improve upon the quality. I don't know that it'll actually increase or decrease access. I think that's our time. So I would give you guys opportunity to have a parting shot, but we don't have time. So thank you. Appreciate you.